Thank you for joining us for this webinar. What we're going to be talking about is osteoporosis, its natural treatments and prevention. Osteoporosis is a condition that has been increasing in severity, even in the most recent last few decades. And it's something that we, by becoming really knowledgeable about this disease, can literally prevent this disease from ever occurring. And we could literally eradicate this disease from ever plaguing anyone again if we could just become knowledgeable of how it develops and how we can prevent it. And that's really what this webinar is all about. Well, let's talk first of all what osteoporosis is. Osteoporosis is a disease which the density and quality of the bone are reduced, leading to weakness of the skeleton and increase in risk of fracture. You see, normal bone matrix is something that is laid down and actually developed by a breaking down of the bone and then laying down the bone. Most people believe that osteoporosis is, a disease that really occurs in old age, and and we really are finding it and discovering it in old age, but it really starts many, many years earlier. And so osteoporosis is something that can weaken the bone and cause spontaneous fractures of the bone, which can affect posture and our ability to be able to stand upright, as well as also causing a weakening of the bone. So if we fall, we can fracture these bones, which can drastically affect our ability to be able to survive. The annual incidence of osteoporosis and fractures in women is greater than the combined incidence of rates of heart attack, stroke, and breast cancer. Now, let's look at this, because fractures, the annual incidence of fractures in women represents this much of the pie. But if you can see, compared to heart attack and stroke and even breast and uterine and ovarian cancer, fracture represents more combined incidence of disease in women than any other particular disease. So this is a very, very epidemic disease in our population, and something that really not much is really looked at or talked about in preventing it. Now, osteoporotic related fractures and its mortality is something that's really amazing when you look at it, because the mortality rate of these fractures as they occur are really much higher than most people think. See, in the population of women, the fracture rate is very, very high, but in men, it's actually even higher. And most people don't think about that, because they think about women really having more osteoporosis. And by the way, women do have larger loss of bone density, and men having usually about 25% higher bone density at any given age, an average of the population. But when men fall and break a hip, their mortality rate is much, much higher than women, than the general population. We see the general population in women being indicated by this line, and then the men is being even higher. But the mortality rate, once it occurs, is stunningly high. See, hip fractures have the highest risk of complications, and 65,000 women die every year from these complications. And this is what's amazing: 24 to 30% increase in mortality within the first year. That means that on the average of 24, maybe even 25%, maybe even 26% of those that fall and break their hips will pass away. It'll be something that will produce mortality, death, in those that fall. So this is something that is not just an inconvenience. This can be fatal in 25% of the people that fall. And there's also a very, very high rate of 50% of these hip fractures that are permanently incapacitated, that they never ever reach full function again from these type of injuries. So this is something that is a great stress on the population, and something that we can do something about. Now let me show you this one particular video that explains the difference between the osteoblast and the osteoclast.
Bone is a dynamic tissue that is continually being built, broken down, and rebuilt in a process called bone remodeling. Bone tissue is broken down and resorbed by multinucleated cells known as osteoclasts. These cells are derived from monocytes which originate within bone marrow. Osteoclasts play an important role in liberating minerals and other molecules stored within the bone matrix. Bone tissue serves as a repository for vital minerals including calcium phosphate and various biologically active molecules, such as growth factors. The release of calcium from the bone can play a role in maintaining its homeostasis within the body. The cells responsible for building new bone tissue are known as osteoblasts. Osteoblasts are thought to be derived from cells found to be associated with blood vessels. Once active, they start to produce the organic component of bone, osteoid, which is predominantly made of collagen. Minerals start to crystallize around the collagen scaffold to form hydroxyapatite, the major inorganic constituent of bone, which contains calcium phosphate. Bone mineral density, or BMD, can be used to estimate the strength of bone and to assess the risk of fracture. As osteoblasts form new bone tissue, many become embedded within the matrix and differentiate into osteocytes. The structure, composition, and cellular processes that occur within bone allow it to simultaneously serve as a calcium reservoir, while providing structural support for the vital organs and for locomotion.
So we see that osteoblasts and osteoclasts are individual cells that break down bone and then lay down bone, so that the bone is actually a living organism within our body. It's a living tissue. It's not a hard, rigid piece of bone as we think about it, but it actually continues to survive and to build itself and break itself down. So let's talk about the causes of bone demineralization, because this is really what we're most concerned about. First of all, diet sodas can do this. People have no concept of this, but especially kids that are being raised on these type of sodas, it can cause a leaching of the calcium out of the bone because of changing of acid-alkaline balance, and it can dramatically decrease our bone densities. What's happening is these kids are not reaching high levels of bone density because of many of the different types of sodas and foods that we're eating. Also, smoking can contribute to this. It can decrease our overall density. Of course, decrease our life in general, but definitely affect our bone structure. Alcohol can do the same thing. Also, calcium and vitamin D deficiencies or malabsorption syndromes can do this. I mean, we can just not have enough calcium or vitamin D in our diet, but also then we can maybe not absorb it as well. And this is very common, where we're not actually absorbing it. Many times, we're going to talk about some other things that can contribute to this, but many times it's not a lack of intake, but absorption. Then also many drugs, and we're going to talk about some of these, can affect how we assimilate and break down bone, and toxicities, and we're going to mention this also. Just environmental toxicities in our body can definitely affect this. And then drugs that reduce bone density, the NSAIDs, the ibuprofen, Tylenol, Elect, the corticosteroids, that's asthma, lupus, severe allergy, and other medications, can drastically demineralize the bone and slow down its production and laying down of that bone. Contraceptives, most people don't realize this, but the pill and the Depo-Provera injections, which are the more long-term ones, can definitely affect our bone density. And this starts out with kids at a very young age and affects their overall maximum bone density. Blood thinners like Coumadin and heparin can definitely affect osteoporosis and the amount of bone that's laid down. Anti-seizure drugs like epileptics can definitely affect bone density, and also proton pump inhibitors. These are the Prozacs, the Prevaceds, the ones that are given for acid reflux. This is a very, very commonly prescribed and also even found over-the-counter medication now, which will affect the amount of acid which accumulates in the pH of the overall stomach, and calcium has to be absorbed in an acid medium. So when we're raising up these individual pHs and stomachs to try to help these symptoms, we're also decreasing the amount of calcium that can be actually absorbed. And then thyroid medications can also affect this. Synthroid has been known to affect calcium absorption and increase the rate of osteoporosis. Now, let's look at some of these medications and the research that goes along with them. See, drug-induced osteoporosis mechanism and clinical implications. This is the American Journal of Medicine, October 2010. It talks about all these different drugs that can cause a disruption of normal production of bone and decrease the bone density in individual people. And so we've got things for type 2 diabetes in here, prostate cancer treatment, fractures, glucocorticoids, casting osteoporotic fractures. There's numerous different things that these medications can affect and ultimately affect our bone density. Also, toxicity. This is what most people don't have any idea about this, but generalized toxicity from environmental factors coming into our bodies can affect the bone density. This is why many times people don't realize that just taking calcium supplements, and not all calcium supplements are equal, but not just taking supplements alone doesn't give them the bone density that they're looking for, because many times you can have toxicity in you of heavy metals and toxic chemicals that will actually decrease your bone density, and by detoxification that we do, it increases the bone density and affects it. So we'd see cadmium-induced effects of bone in a population-based studies took blood and urine from 120 people and increased heavy metal cadmium exposure correlated with decreased bone mineral density. Effects on bone mineral density were magnified on post-menopausal women. So the fact that we can become toxic and actually decrease our bone density, which I believe is happening at an alarming rate, that the toxicity that's occurring in our environment is definitely affecting all kinds of different physical problems, osteoporosis being definitely one of them. Now, traditional medical interventions basically are hormonal replacement therapy, which is HRT, or biophosphonate drugs, which are Fosamax and Beniva and many other types of drugs that we see and are being utilized. Now let's just take a look at a little bit of some of the side effects of these drugs. First of all, HRT, hormone replacement therapy, which was used just widespread throughout the women population, the female population, for years and years, with everybody saying that it was totally safe. And I had tremendous problems with this and told my patient population to stay away from it for years and years. And finally, all of a sudden, of course, we have a bunch of research that comes in that says that we have side effects of stroke, there's side effects of blood clots, there's heart disease that goes on with it, breast cancer. My own mother died from side effects of hormone replacement therapy with breast cancer, and it was a very painful and long and very arduous death that she had, which I will never forget myself personally. And uterine endometrial cancer, as well as gallstones, ovarian cancer, and dementia are all side effects of HRT. And so therefore, this is an alternative to help build our bone, which it does increase bone density somewhat. It was totally unsatisfactory, and so HRT has not been used anywhere near as much as it had been in the past. It's very seldom used now, and still used somewhat, but not at the rate it was. And therefore, we've gone on to the biophosphonate drugs to try to build bone in allopathic medicine, classic medicine. So let's look at some of the adverse effects of the biophosphonate drugs. First of all, Mayo Clinic Proceedings, July 2009, said this, that acute phase reactions of fever, malaise, arthralgias, severe muscular pain, hypokalemia, which is severe decreased calcium in the blood, which can affect heart and several other different type factors in your overall health, as well as esophageal cancer, ocular inflammation, osteoporosis of the jaw, which is in the temporomandibular joint of the human body, which is the jaw, that causes actually the jaw to actually lose bone density, and you get necrosis of the joint. It's actually a degeneration of the joint, as well as atrial fibrillation, which is something that's increasing like crazy in our population. We've never seen so much atrial fibrillation. People are having it time and time again, leading all kinds of medical innovation of ablation and everything else to get this to get improved. And I believe a lot of this is occurring from medications as well as toxicity in our environment, and severe suppression of bone turnover. We, instead of having this normal dynamic osteoblast lay down of bone and then osteoclast taking up of the bone and having this dynamic healthy exchange of a living process, these drugs lay down this almost cement-like molecule that goes into the bone and just basically causes a severe suppression of this bone turnover, and makes your bone hard. It makes it very brittle. So people say, well, that's what we want. No, we want it strong. We don't want it brittle. We don't want it just hard. And I believe some of these DEXA scans and bone studies that have been done after the use of these biophosphonates is showing increased bone density, and what's really showing is increased hardness, not necessarily strength. And that's really my concern, because we're seeing tremendous amounts of trochanteric femoral fractures, where there's been a call been put out by emergency rooms all over the country that are seeing women spontaneously fracturing long bones, the femur right underneath your hip. When people are stepping off of curbs, and these long bones are just fracturing out from underneath ladies, and all these people are on these biphosphonate drugs. Now, this doesn't happen all the time, but it's happening, and therefore it's telling us that we're not necessarily producing stronger joints or bones. It could be we're just producing harder and more brittle ones. So let's take a look and see what the big problem is. See, the prevention and the peak bone mass is what we have to look at, because we have women, men building bone. This is the rate at which men build their bones. See, we see at earlier ages here, at 20 years old, the bone density increases, and it comes up to a peak right around late, say 30s or so in a man, and then it slowly decreases down. Okay, if this rate of decline is slow enough, then by the time the person gets old enough, they still have enough bone density and there's no problem. See, the problem starts here. See, we see with this women's graph, women don't even get as high of a bone density as men do, and yet their drop in overall rate of bone density is much faster than men, and because of that, they end up having a much lower density of bone than men will, and they can end up having a greater rate of fracture. So the key to bone density is trying to get women when they're about this age and be sure that their bone density is maximized. If we get way up here, and then under design clinical nutrition, we have a lower, slower rate of decline and even a higher mass to start out with, then later on in life we have plenty of bone and we basically eliminate osteoporosis. Now, my question is, why isn't anybody telling anybody about this? Why isn't there a push to get young women to get their bone density maximized? I mean, I had a woman come in my office the other day, and in her late 30s, 38 years old, she already has osteopenia shown up on a bone density scan. Now, if she is already way down in here at 30 years old, where do you think she's going to be when we get her over here, when she has a very steep decrease without anybody slowing this down? She's going to have very fragile bones, and then, of course, all of her answer is to put her on biophosphonates. If we actually can get these people's bone up here and then have a way to monitor them as they go throughout life, keeping a supplement program that keeps their bone density really high, they will never get it, never need the drug. And that is our goal. Also, we decrease the chance of fracture, spontaneous mortality in 25% of those people, and all the rehab and cost that occurs, and of course all the tragedy of and pain and suffering of the injury. So this is something that can be very, very easily handled if we just get a little bit of education in the population and use some of the tools that we have to be able to do it. So one of the things that we have is a breakthrough bone marker. This bone marker was actually used with HRT therapy. They used it. It's called a NTX, as we're going to see here, and it's something we can use as just a simple urine test. It's a very inexpensive urine test that costs $30 that we can get done, that actually measures the amount of this particular fraction. See, as these osteoblasts start to lay down bone, they come and hit the bone, and when they do that, it lays down bone. Now, the osteoclasts come along, and they will resorb the bone. Now, when this occurs, an NTX, it's a nanotelepeptide, which is related to the osteoclasts. When this calcium is released from the bone, these NTX molecules actually are also excreted from the bone, and then we end up with bone that has been reabsorbed. But these NTX molecules also are released as the bone is released. So we end up having these particular molecules to measure, to give us an idea of just how much bone is being released, and calcium is being released from the bone as the bone is being worked on by the osteoclasts. So it gives us a real good idea of how fast you're losing calcium from your bone. A very inexpensive test that gives us a good measurement. Now, like I said, it was used for HRT, but it got lost. This test got lost when HRT stopped being used. And we pulled this test out of the archives of LabCorp and have been used it in nutrition, and it's working fantastic to give us an idea of exactly how our nutritional programs have been working, and give us an idea of just how fast people are losing bone. So when we see the N-telepeptide bone density research, we see the early changes in biochemical markers of bone is a good turnover predictor of bone mineral density. We see 138 postmenopausal women of osteoporosis. Conclusion was percent change of the NTX at 3 months correlated with a percent change of the body mass index at 12 months. So we can get a good idea of the body mass index, what's going to happen, by looking at this NTX value. Now, osteoporosis is a whole body problem. A lot of people think that all you got to do is take calcium, and if you calcium, your bones going, you go get your calcium at Walmart, and you take it and you're going to be fine. Well, unfortunately, it's not that simple, because as you can see here, we got dietary calcium coming into a stomach. Like I said, if the pH of the stomach's not correct, then all of a sudden you're not going to absorb this calcium, and then you can lose it down here farther in absorption in the gut, and then you can lose it in intracellular fluid. You can have parathyroid problems that can cause calcium not to be absorbed correctly. You can also have problems in the kidney itself that affects calcium. You also can get calcitonin in the thyroid, and then you can get parathormone, which is releases that affects how calcium is absorbed in the bone. And so you can get it can be a whole body problem. So when we evaluate people for this, we like to do a whole body analysis on them to be sure there's not any other factors that could be slowing down this process, rather than just simple calcium deficiency. The big answer to everything in medicine in this is just go take some calcium. Well, unfortunately, it's not that simple. And but if we do it correctly with a good analysis and then monitor it with the NTX, we get some great results. Now, just look at this. This was a study that measured supplementation with pharmaceutics. All those side effects that we saw, and nobody is telling anybody that with just good supplementation and a good body workup and be able to take care of people and doing this early, that we can change this. They had on the femoral neck, natural supplementation produced a 4% increase in bone density, and Fosamax only did 2%. Total hip, 3%, 2%. Total spine, 6%, 4%. So we have pharmacology not even standing up close to what supplementation can do. And also the body mass index of the femoral neck increased 5%, 3%, and 6% with, and this is people that had failure to respond to previous biphosphonate therapy. So people that did not respond to previous biphosphonate therapy actually took supplementation and got 5, 3, and 6% increase overall bone density. I don't know how people get away with selling these things with all these side effects when we can get such great results with correctly given supplementation. Now, this particular study, they threw a bunch of supplements at people. There was much more than what was put on here. And they got at the end of the study and said, we're not even sure what worked. We don't know what did it, but something we did seemed to make a difference. Now, if we could not only just throw stuff at people, but actually test individual supplementation and then compare it with the blood test to see if it's working, how much better would that even work? And we're finding that to be the case in our office. So what is the advantages of Design Clinical Nutrition? First of all, it's neuromuscular nutrition based exam. Okay, we use specific testing to get a good idea what your body wants. All right, we use a nervous system to determine which specific nutrients the body needs, and usually we can get this protocol down to 2 to 3 supplements at the most, not needing to take 5, 6, 7, 8, 10 supplements as in that study. So here is a couple case studies. Here's a 62-year-old female who had a nanopeptide level of 62, which put her into almost the 4th category of extremely accelerated calcium loss from her bone. Now, we can see after supplementation, and it drops to a 49, so that she dropped out of that real severe category. This was only in a very short period of time of maybe 2 or 3 months. This is already starting to drop. Then, to show you these stores and this is just totally with supplementation. We had one that had 110. This is extremely fast. This person's losing bone very, very quickly. Okay, normal should be like under 34, and she's got 110. So she's extremely fast rate of demineralization of her bone. After treatment, we see in 1013, it dropped from 110 down to 47, which is almost puts her in the 2nd category from the 4th category. Much slower decrease in rate of bone density loss, and definitely moving in the right direction. Now, this was really interesting because this same patient in 2007, all the way to where she had in 2012, she had no difference, actually a decrease in overall bone density in her DEXA scans in those 2 years. She starts treatment with us, and within 2 months, or 3 months, she has a 5% increase in her overall bone density. So she has 2 years in a row, or even several years, or 2 years, where she had DEXA scans showing she's getting worse. She starts the treatment, and she has a bone mass density increase of 5%. So, without a shadow of a doubt, this particular patient is the same one we saw that went from 110 to the 47. We can change these bone densities by doing the supplementation and don't need to use a lot of the very strong pharmacology with all the side effects that's involved. So, that's our webinar, and we're really glad that you guys had a chance to be with us, and we look forward to seeing you at the office where we can evaluate you more if you're interested in this. We have a very inexpensive evaluation procedure that we can use to evaluate you and start you on a nutritional program that can prevent this. And if you have any additional information, feel free to call us at the office. And thank you for listening to this webinar.